as we move on to the next session, that's on emergency echocardiography track, decision making. He's being joined by Professor Naveen Nanda, and along with them are Professor Asha Murthy and Professor S. Ramakrishnan. Ladies and gentlemen, we've got 3 lectures, each of them for 20 minutes each, and then we'll have all the discussion at the end. The opening lecture is on VSD after myocardial infarction, and we'll have Dr. K.K. Kapur, Senior Consultant Cardiologist at Indraprastha Apollo Hospitals in New Delhi. Citation for our invited speakers, Professor Iyengar. This was the award which was conferred, as yesterday he couldn't join us, for the contributions in cardiology in the world, and that's the token of appreciation to Dr. Yadav. Thank you very much. We now move ahead to the next segment, and the first lecture is on VSD after MI, to be delivered by Dr. K.K. Kapur. He's a senior consultant cardiologist from Indraprastha Apollo Hospitals in Delhi. Dr. Kapur, please.
I would like to, at the outset, thank Dr. Chopra and the other organizers of the WCCPCI 11th edition. And I'm very happy to be here at Mount Abu. And I'll be speaking on the topic of VSD after myocardial infarction. Now, the VSD after MI is becoming increasingly uncommon as compared to the pre-thrombolytic era, where it complicated 1 to 2% of acute myocardial infarctions. Now it is complicating somewhere between 0.17 to 0.31. So it's gone down by about 1/4 to 1/5. And those who are treated with PCI early, then they have the lowest incidence, while those who were treated with the thrombolytic had a little higher incidence, and those who did not receive either the thrombolytic or the PCI, they had a higher incidence. Mortality is still high, although the incidence is becoming less. The operative mortality and mortality after VSD is high, depending upon the hemodynamic consequences of VSD and the amount of the necrotic myocardium, as well as the friability of the myocardium. The pathophysiology of VSD after myocardial infarction is of 2 types. If it is delayed, that is the classical variety, is 3 to 5 days after myocardial infarction. You have a coagulation necrosis of the ischemic tissue with neutrophilic infiltration, which eventually causes thinning and weakening of the septal myocardium. Then, the more recently, what we have seen is sometimes it occurs within 24 hours of myocardial infarction, and that is likely to be due to dissection of an intramural hematoma or hemorrhage into an ischemic myocardium. The ventricular septal rupture seems to occur with similar frequencies in both anterior, inferior, and lateral infarctions. The anterior infarction are more likely to cause apical defects, while the inferior or lateral infarctions are more likely to cause basal defects at the junction of the septum and the posterior wall. And what are the risk factors? Old age, female sex, history of stroke, chronic renal failure, and congestive cardiac failure. These are the risk factors, and those that are statistically less likely to be associated with the ventricular septal defect are hypertension, diabetes, smoking, and a previous history of myocardial infarction. Due to the increased awareness and availability of color Doppler echo in the emergency, the VSDs are diagnosed much earlier, and therefore they are managed according to the guidelines. The early intervention, it limits ischemia. You can measure the size of the VSD, you can quantify the shunt, and you can also assess the PA pressures from the gradient across the VSD, or if you are not able to get parallel to the gradient, you can take the help of the tricuspid regurgitation jet. And sometimes there is a coexistence of MR post-VSD that can either be due to associated rupture of the papillary muscle, which is rather uncommon to have both in the same patient, or it could be due to the left ventricular dysfunction itself causing mitral regurgitation. And you can also assess the success of the intervention if a percutaneous closure has been planned. Now this, for example, is a patient, a 70-year-old male, 1 month after the ventricular septal defect. He has survived the VSD, but has still got a fairly large shunt across the VSD, got some left ventricular dysfunction, and ideally he would be a candidate to have a transcutaneous closure, device closure in view of his age, or he could of course have a surgical repair itself depending upon the comorbid conditions. The transthoracic echo of course reveals an anterior MI in the mid-anterior septum, and you can see the transesophageal echo clearly showing a large ventricular septal defect, and therefore this has to be closed. Now this is a patient, 50 years old female patient, post-anterior wall MI with breathlessness. Echo showed a ventricular septal defect at the apex. You can see this is also an anterior MI, and this MI was closed using the DOR procedure. This was closed via the DOR procedure, where directly the VSD was not touched. It was just that the apical segment of the left ventricle was excluded by putting a patch and then allow the apical segment to clot. But unfortunately in this patient there is a leak across that patch. This is called the DOR repair, which is used to repair the ventricular aneurysms. The advantage of using the DOR repair versus the patch closure is that the tribal VSD can be taken care of. That the tribal edges of the VSD can be taken care of, and therefore you don't need to come anywhere near those edges, so you can avoid those edges of the tribal segment, and you can just put a patch across the non-tribal area of the left ventricle and exclude the apical segment. Now this is a patient who had an inferior MI, 1 month post-inferior MI, has a basal VSD, which is seen as large basal VSD, which can be clearly seen, and this patient also was in congestive cardiac failure and has a dilated inferior vena cava. And when we did the transesophageal echo, you could see a very large ventricular septal defect in this patient. And in this patient, you can see a large basal VSD, and you can clearly see a very huge shunt. And this patient had a closure of the VSD, and this was actually an intraoperative TEE. And when we repeated the TE as the patient came off the cardiopulmonary bypass, you can see the intracardiac air, which was taken out. And then, of course, you can see the patch nicely in place, redundant patch, and which is closed, which has effectively closed the ventricular septal defect. So when you come to the surgical repair post-MI, for how the post-MI, there are a lot of technical issues that have to be taken care of. One is that during the acute stage, as I mentioned, you have a friable necrotic myocardium, and the sutures are likely to cut through. And also, if the VSD is in the evolving phase, the size of the VSD is also likely to increase. So in that case, it is better to avoid repairing the VSD in the acute stage, and if possible, you can manage. If the patient is hemodynamically stable, then it's better to manage him conservatively and with a close follow-up. And by the 2nd to the 3rd week, you could consider closure of VSD, as the edges of the VSD, they undergo scarring and they are more likely to hold. So delay the surgery if possible, and the patient is hemodynamically unstable. Obviously, you put in a IABP or sometimes you even may have to use an ECMO to tide over the acute phase. If the patient is hemodynamically unstable, then ECMO may have to be used to tide over so that by the second week you could attempt closure of the VSD. Otherwise, at that stage it could cut through. And even if you're planning on a door operation, you have to have an adequate myocardium that is available to you so that you can just you can just exclude the VSD part of the myocardium by a patch. But that also is only possible if the VSD is not extending further and if the other part of the myocardium is quite healthy. So it's only the door repair is used if you have a healthy, non-friable myocardium that is available. So if you have a VSD after myocardial infarction, you can have a hemodynamically unstable VSD, you can have a stable large VSD, or you can have a stable small VSD. In the case of a hemodynamically unstable, you will of course do immediate surgery, and then depending upon the myocardium, you might have to use an ECMO, or you can also consider percutaneous closure if no valve is involved, and then he is not a future surgical candidate. Sometimes, but there also you need the myocardium to be relatively healthy, even if you are doing a device closure. If the device has to hold, then the myocardium has to be healthy, but sometimes you can just reduce the size of the VSD by putting a device closure, and you could consider surgery afterwards. The patient stabilizes with that. Otherwise, it is a difficult condition to manage. If you have a patient who is stable with a large VSD, then in that case it's better to do close monitoring and delayed surgery for at least 2 to 3 weeks. If it's a stable small VSD, you could just consider either a long-term conservative management, or in case the shunt is still excessive and the patient is going into repeated pulmonary edemas, then in that case you could consider a delayed surgery or a percutaneous closure. So the proposed approach is VSD, whether it is stable, unstable. If it's unstable, you stabilize with IABP and you see what is the risk of the surgery. The standard risk is about 20%. Anything above that is not acceptable. Then you will operate with a patch closure or a door by exclusion surgery. And if it is inoperable, you could consider percutaneous closure with the same problems, that you should have some sort of a healthy myocardium around the VSD for the device to hold. And if there's a recurrence after patch closure, you could also consider device closure. If it's a stable patient, you could wait for about 2 weeks. And if the patient is a high risk in shock anuria, then in that case, you could have a further assistance and wait, and then try to close the VSD. The outcomes, the surgical outcomes, would depend upon when it is performed. In the acute stage, you have a high mortality, as I mentioned earlier, a 60% unacceptable mortality. Less than 7 days, it's 54%, and more than 7 days is more acceptable. Now, this is the percutaneous device closure using the implants VSD occluder, specially designed for a post-MI VSD. And you're also seeing a pathological specimen of the patient who could not make it even after device closure. So this is a patient, 80-year-old female patient, presented with chest pain. ECG showed anterior MI, systolic murmur, and a percutaneous closure was attempted in this patient. But unfortunately, when the percutaneous closure was attempted, there was a lot of leakage around that device closure, even though the device was in fairly good position, but there was a leakage around the device because of the friable myocardium. So this patient ultimately could not make it. She had septicemia, to which she succumbed. So when you look at the complications of the post-MI VSD, the most authors, they suggest a defect less than 15 millimeters is optimal for a percutaneous repair, for a percutaneous VSD closure. But again, in these patients, you have immediate mortality 3.8%. Surgery may still be required in another 7.5%. The device could embolize. The patient could have a late mortality also, quite a bit. So in all the likelihood, present and future, attempts to utilize various percutaneous septal occluders as a substitute for the patching of the ruptures are prone to fail because the necrotic septal tissue has very little in common with the healthy septal tissue. Thank you for your attention.
Thank you, Kapur, for your nice presentation. I'd like to say one word that normally in the acquired VSD, after the post-MI, the edges are crenated. And unlike the congenital VSDs, the size has to be larger so that they eat away the edges. So I think that was one of the reasons that the size was less shorter and there was a residual shunt after the closure with the device closure. So you agree?
It can also extend further because it is an ongoing and that area around the
Dr. Kapur, can you just speak on the microphone for the betterment of the audience? Could you please speak on the microphone?
So that area around the VSD is certainly not healthy. And this myocardial infarction is still in the process of evolving. So at that stage, because of the large shunt and because it was more than 1.5 centimeters size of the VSD, it could not hold on. And there was leakage around the VSD.
I'd like to make some more comments. I mean, you didn't show, because sometimes there's a VSD is simply you have an opening on the left side of the septum, and then there is a septal hematoma. So the septum actually enlarges. And then there is communication from the septum into the right ventricle. And that can be more than one, can be multiple communications. So sometimes the VSDs can be these are some of the VSDs that you showed are more like simple VSDs, but some of the VSDs are more, ventricular septal rupture, I should say, are more complicated, where you have a septal hematoma with one rupture on the left side, but multiple ruptures on the other side, or may not be in the same plane, maybe another plane. And sometimes the 3D echo is very useful in some of those instances. The other thing I need to make is that once in a while you have a patient with MI, you hear a murmur, you think it's a VSD, and then when you this is one of the points you made, you find out that it was actually a perimembranous VSD. So it's nothing to do with rupture. So all VSDs, there may be a coexisting congenital VSD with MI. You have to really be careful not to diagnose that as a VS rupture.
This was an acquired VSD.
Yeah, no, I know. I mean, sometimes, you can't make out sometimes, You may have an VSD which has nothing to do with MI, which is actually, but so you have to be very careful with that. And thirdly, I think you should always look at the right ventricular function, because that is one which determines, one finding which determines the prognosis. If the right ventricular function is poor, the prognosis is very, very poor. On the other hand, the right ventricular function is better, then prognosis is better in these cases. So those are the 3 points.
Thank you very much, Dr. Kapur.